Good morning, everyone. This is Professor Osorio. Today, we are diving into two critical concepts in advanced nursing care: shock and hemodynamic monitoring. Understanding these concepts is vital for managing patients in critical condition, where timely recognition and intervention can make all the difference. We'll explore the various types of shock, their physiological impacts, and how hemodynamic monitoring helps us assess and guide treatment. By the end of this lecture, you'll be confident in recognizing shock states and using monitoring tools to improve patient outcomes. I considered breaking this lecture into smaller segments, but ultimately decided to keep it as one recording. I understand it's a bit lengthy, so please pace yourself while listening and take breaks as needed. Also, feel free to reach out if you have any questions. So, let's get started. Shock is a condition where the circulatory system fails to deliver enough oxygen to tissues, which disrupts the balance between oxygen supply and demand. This leads to poor blood flow or hypoperfusion, causing cells to struggle to meet their energy needs, ultimately impairing cellular metabolism. In today's lecture, we will cover some essential topics related to shock and hemodynamic monitoring. We'll start with a review of key terminology to ensure everyone is familiar with important concepts. Then we'll dive into hemodynamic monitoring, a critical tool in assessing cardiovascular function and guiding interventions. Next, we'll explore shock, starting with its definition and the role of SIRS or SIRS, systemic inflammatory response syndrome, in the body's reaction to shock. We'll examine the types of shock, their causes, and how each type uniquely affects the body. We'll also discuss treatment approaches to shock, focusing on restoring adequate circulation and oxygenation. As we proceed, we'll cover the pharmacological agents commonly used in shock management, and finally, we'll highlight the potential complications that can arise if shock isn't promptly and properly managed. By the end of this session, you should have a clearer understanding of shock pathophysiology and the tools available to support critically ill patients. Preload refers to the initial stretching of the cardiac muscle fibers as the ventricles fill with blood. It is influenced by the volume of blood returning to the heart or the venous return and affects the heart's ability to pump effectively. Afterload is the resistance the heart must overcome to eject blood from the ventricles. It's largely determined by vascular resistance, especially in the arteries, and influences how hard the heart must work to circulate blood. Contractility refers to the strength of the heart's contraction. It is the ability of the heart muscle to contract and pump blood, independent of preload and afterload, but can be influenced by factors such as calcium levels and certain medications. These terms are key components of hemodynamic monitoring and help us understand the heart's performance under various conditions, so familiarize yourselves with these definitions. You will also find them on your book, page 525. Preload is the volume of blood filling the ventricles just before they contract, which determines the initial stretch of the heart muscle fibers. It is the load to which the cardiac muscle is subjected before shortening. This refers to the pressure or load the heart muscle experiences as it fills with blood before it contracts. It is also the degree of ventricular stretch at end diastole, or how much the heart muscle fibers are stretched by the volume of blood during preload. Frank Starling's law explains that the more the heart is filled, as in increased preload, the stronger the heart contracts, up to a point. However, overstretching can lead to reduced efficiency eventually. So, what affects preload? Factors such as blood volume, venous return, and heart rate affect preload. How can we therapeutically manipulate it? We can increase preload with fluids or blood products, and reduce it using diuretics or vasodilators to manage fluid balance and optimize heart function. Afterload is resistance to ventricular ejection during systole. Afterload is the force or resistance the heart must overcome to eject blood during systole. Systemic vascular resistance refers to the resistance faced by the left ventricle, while pulmonary vascular resistance refers to the resistance the right ventricle faces when pumping blood through the lungs. The heart must generate enough pressure to overcome afterload and push blood through the valves and into circulation. As afterload increases, the heart has to work harder and harder to pump blood, which generally leads to a decrease in cardiac output. The push, as it is referred, is the force needed for the heart to pump blood against the afterload. Now, what affects afterload? Factors like blood vessel diameter, blood pressure, and valve conditions impact afterload. How can we therapeutically manipulate afterload? Medications like vasodilators can reduce afterload by relaxing blood vessels, while vasopressors can increase afterload by tightening vessels, depending on the patient's needs. The force of mechanical contraction is referred to as contractility. It is the strength of the heart's contraction during systole. It is also related to increasing intracellular calcium or with sympathetic stimulation. It increases with higher levels of calcium inside the heart cells or increased stimulation from the sympathetic nervous system, which enhances the heart's ability to contract. The squeeze, as it is referred to, is a colloquial term for the heart's ability to contract and pump blood effectively. Ejection fraction, or more commonly referred to as EF, is a measurement used to assess how much blood the heart pumps out with each contraction, typically as a percentage of the total blood volume in the ventricles. You'll see a normal reading of 55 to 65%, depending on what the patient goals are. What affects contractility? Factors such as oxygen supply, calcium levels, medications, and nervous system activity can influence contractility. Therapeutic manipulation is done through medications like inotropes, for example, dobutamine, can be used to enhance contractility, especially in conditions like heart failure where the heart's pumping ability is compromised. Hemodynamic monitoring provides vital data on how effectively the heart and blood vessels are circulating blood and oxygen throughout the body. These measurements can be obtained through less invasive techniques like blood pressure cuffs or more invasive ones like arterial lines or pulmonary artery catheters. Monitoring systemic and pulmonary arterial pressures help assess the function of the left and right sides of the heart, respectively. Venous pressure measurements, such as your CVP or central venous pressure, help to evaluate blood return to the heart and fluid balance. Here's a summary of the key hemodynamic parameters listed in this slide. Heart rate is the number of heartbeats per minute. Blood pressure, the force of blood against arterial walls, measured as systolic over diastolic pressure. Your CVP is the pressure in the large veins returning blood to the heart, used to assess fluid status and venous return. Pulmonary artery wedge pressure, or PAWP, reflects left atrial pressure and is useful for assessing left ventricular function and fluid status. Cardiac output, or cardiac index, is the amount of blood the heart pumps per minute, and cardiac index is the cardiac output adjusted for body surface area. Stroke volume, or stroke volume index, is the volume of blood ejected per heartbeat, and SVI is stroke volume index to body size. SaO2 or oxygen saturation of arterial blood the is the percentage of hemoglobin saturated with oxygen in the arterial blood. SvO2, that's your mixed venous oxygen saturation, and ScVO2 is your central venous oxygen saturation. These are indicators of oxygen delivery and consumption at the tissue level, which we'll talk about more. SVR, systemic vascular resistance, and PVR, pulmonary vascular resistance, we talked about, are measures of the resistance of the heart are measures of the resistance the heart must overcome to pump blood through systemic or pulmonary circulation, respectively. These parameters are essential for assessing cardiac function and guiding clinical interventions, especially for your critically ill patients. So, we could use monitoring equipments like a cardiac monitor continuously to monitor the patient's heart rate and rhythm in real time, providing vital information about cardiac function, of course, and blood pressure monitoring through a blood pressure cuff and stethoscope to manually measure blood pressure. Or you could use a continuous arterial line, which is an invasive method using an arterial catheter to continuously monitor blood pressure in real time. Typically, this is only used in the ICU. CVP is measured using a central venous catheter, which can have triple lumen, double lumen, or a power pick configurations, allowing for multiple infusions, blood draws, and CVP monitoring. A pulmonary artery catheter, or a PA line, or a PAC, depends on where you work, is used for measuring pressures in the pulmonary artery and monitoring hemodynamics such as pulmonary artery pressures, your PAWP, and cardiac output. Arterial pressure monitoring involves inserting an arterial catheter, typically into the radial femoral or brachial artery. This catheter is connected to a transducer that converts pressure signals into a waveform displayed on a monitor. It provides accurate moment to moment data on systolic, diastolic, and your mean arterial pressures, making it crucial for managing these critically ill patients, especially when they are on vasoactive medications or those who are very hemodynamically unstable. Arterial pressure tracing is a good visual representation of blood pressure throughout the cardiac cycle. It's shown as a waveform on a monitor, and it has several key components. Here you'll see the systolic phase, which is the highest pressure in the artery when the heart contracts, as in systole, and pumps blood into the arteries. You'll also notice a downward deflection that follows the systolic peak, and this is called the dicrotic notch. This marks the closure of the aortic valve and indicates the transition between systole and diastole. The end diastolic phase is the lowest point on the waveform, representing the pressures in the artery when the heart is relaxed, as in diastole. You'll also notice the QRS complex on the ECG, representing ventricular depolarization. And this is corresponds with the beginning of the arterial waveform's rise as the ventricle contracts and ejects blood during systole. The components provide insight into cardiac function and vascular health in real time. Here is the formula to calculate your MAP, where the MAP pressure is the average pressure in a patient's arteries during one cardiac cycle, representing the perfusion pressure reaching the organs. MAP should always be at least 65 millimeters of mercury. This is the minimum needed to ensure adequate perfusion to vital organs, especially the kidneys. Normal map range is 70 to 105 millimeters of mercury. This range ensures that organs and tissues are receiving sufficient oxygenated blood. Okay, let's talk about your central venous pressure monitoring or CVP. The CVP represents the preload of the right ventricle or the pressure of blood returning to the heart, primarily reflecting the mean right atrial pressure or RAP. Sometimes people would interchangeably use RAP and CVP when they're labeling on the monitor. CVP is measured through the proximal port of the pulmonary artery catheter or a triple lumen catheter. CVP typically ranges from 2 to 8 millimeters of mercury, but do make a distinction for when we start talking about sepsis. This is an important hemodynamic parameter to evaluate fluid balance and cardiac performance, especially for your very critically ill patients. A CVP waveform reflects the pressure changes in the right atrium and provides insights into the right function and the right heart function and fluid status. The waveform is typically broken down in several components, each corresponding to a phase of the cardiac cycle, and that's really all you need to know about that central venous tracing. So, PA pressure monitoring provides real-time data on the pressures within the pulmonary artery, offering insight into both right and left heart performance. While pulmonary artery wedge pressure was historically used to assess left ventricular preload for patient safety, many cardiologists now prefer that only they perform the wedging procedure. As a result, nurses typically monitor pulmonary artery systolic and pulmonary artery diastolic pressures instead. Your normal pulmonary artery systolic is 15 to 30 and diastolic 8 to 15 millimeters of mercury. These values are crucial for managing patients with heart failure, pulmonary hypertension, and other cardiovascular conditions, helping us guide the fluid management and make therapy adjustments based on it. So, again, pulmonary artery pressure monitoring guides management of patients with complex cardiac, pulmonary, and intravascular volume problems, providing critical data for decision making. Your PA diastolic pressure or PAD and PA wedge pressure, PAWP, are indicators of cardiac function and fluid volume status. PAD pressure reflects left heart function actually, while PAWP, pulmonary artery wedge pressure, helps assess left ventricular preload. PA catheter guides the therapeutic manipulation of preload. By monitoring these pressures, clinicians can optimize fluid management and improve cardiac output. It also enables measurement of how well the heart is pumping blood, again by monitoring the cardiac output. A pulmonary artery catheter, also known as a Swan-Ganz catheter, is positioned through a central vein, usually internal jugular, and threaded through the right atrium, going through the right ventricle, and into the pulmonary artery. When the catheter reaches the pulmonary artery, the balloon tip is inflated and to temporarily occlude the artery. This allows the measurement of your pulmonary artery wedge pressure, which again reflects left atrial pressure and helps assess left ventricular function and preload. The balloon is deflated after the measurement to ensure blood flow is restored and to prevent damage to the pulmonary artery. It is important that the balloon is only inflated under specific conditions, again, often with the cardiologist present due to the associated risk. Pulmonary artery pressure is measured using the distal port of the pulmonary artery catheter when the balloon is deflated. This allows for continuous monitoring of pulmonary pressures without occluding the artery. For normal values, think of quarter over dime or a range close to 25 over 10 to help you with a quick reference. The waveforms provide a visual representation of the pressures in the pulmonary artery throughout the cardiac cycle. There are key components here, kind of similar to what we talked about with the arterial line. I don't really need you to know the specifics, for this is very advanced. Pulmonary artery wedge pressure, also known as pulmonary capillary wedge pressure or left ventricular end diastolic pressure, LVEDP, is a key measurement used to estimate left heart preload and left ventricular function. It is measured by inflating the balloon at the distal port of the pulmonary artery catheter. The inflated balloon occludes the pulmonary artery, allowing pressure measurement that reflects the left atrial pressure. It looks ahead through the lungs and open mitral valve. This measurement then reflects pressures beyond the pulmonary circulation, essentially providing an estimate of your left ventricular pressure. The pulmonary artery wedge pressure approximates your left ventricular end diastolic pressure very closely by indicating the pressure within the left ventricle at the end of diastole. Your normal PaWP pressure range is 6 to 12 millimeters of mercury. So to measure your PaWP, the balloon should be inflated slowly with air until the pulmonary artery waveform changes to a wedge waveform, which reflects left atrial pressure. The balloon should be inflated for no more than 4 respiratory cycles, or approximately 8 to 15 seconds, to prevent prolonged occlusion of the pulmonary artery, which can cause complications such as pulmonary artery rupture or ischemia. Remember that you can't just use any syringe to inflate this balloon. There is an automatic deployable syringe that sucks the air out for when you are no longer wedging, and it usually comes with the packaging for your pulmonary artery catheter. This procedure provides important information about left heart function, but must be done carefully and only for a brief period of time to ensure patient safety. Stroke volume is the amount of blood ejected by the ventricle with each heartbeat. It reflects the efficiency of the heart's pumping ability and is crucial for understanding cardiac output and overall heart function. Technologies like NICOM, or your non-invasive cardiac output monitoring, and CHEETAH are being used to assess stroke volume without invasive procedures. These systems provide real-time data on fluid status and cardiac function, helping clinicians optimize fluid management in critically ill patients. Non-invasive methods like NICOM are particularly valuable in reducing patient risk while obtaining critical hemodynamic data. Cardiac output represents the total amount of blood pumped by the left ventricle every minute and is calculated as cardiac output equal heart rate times stroke volume. Your normal cardiac output typically ranges from 4 to 8 liters per minute, depending on the individual's metabolic needs. Now, cardiac index adjusts the cardiac output for body size by dividing the cardiac output by the body surface area. This helps provide a more accurate measure of heart function relative to the patient's size. Normal CI, or cardiac index, ranges from 2.5 to 4 liters per minute per meter squared. Systemic vascular resistance, or SVR, has a normal range between 800 and 1200 dynes per second per centimeter to the negative fifth power, and is calculated when cardiac output is measured. Mixed venous oxygen saturation, or SVO2, reflects the amount of oxygen returning to the heart. Normal value is approximately 75%. It's considered a warning sign if the value is out of range or changes by more than plus or minus 10%. It's measured using a PA catheter or a variation called SCVO2 through a central line. It must be a central line. SVO2 and SCVO2 values are used to assess the balance between arterial blood oxygenation, tissue perfusion, and tissue oxygen consumption. SVO2 helps clinicians assess how well oxygenated blood is being utilized by tissues and is particularly valuable in critical cardiac postoperative care patients. This diagram illustrates the concept of oxygen delivery and consumption, which is crucial in understanding shock states. The venous oxygen delivery of 750 ml per minute represents the amount of oxygen delivered to the tissues via the venous system. The SVO2, which is your venous oxygen content, is the oxygen saturation of the blood returning to the heart after passing through tissues with a normal value of 75%. This shows how much oxygen the tissues did not use. Arterial oxygen delivery, about 1,000 mL per minute, refers to the oxygen carried by arterial blood. It's provided by cardiac output and measured via arterial oxygen content, your SaO2. Oxygen extraction is when the body typically extracts about 25% of oxygen from arterial blood for tissue metabolism. It occurs at a rate of 250 mLs per minute. So again, this diagram shows the balance between oxygen delivery, DO2, and oxygen consumption, VO2, essential in understanding shock. A drop in cardiac output or oxygen delivery can compromise tissue oxygenation, which is key in conditions like shock. In shock, when oxygen delivery fails to meet tissue needs, SVO2 decreases, indicating insufficient oxygen is returning to the heart, which signals increased tissue extraction or decreased oxygen supply. Please know these normal values, especially for reference. I want to reinforce that patient specific factors, such as their surgery type and recovery status, should guide the interpretation of values like cardiac output, cardiac index, and SVO2. For example, a cardiac index of 2 is often acceptable for patients recovering from open heart surgery. These patients may not reach normal values immediately after surgery. Cardiac index, again, remember, adjusts cardiac output based on body surface area, making it a more individualized measure. SVO2, mixed venous oxygen saturation, gives insight into how much oxygen is returning to the heart after tissue consumption. It is measured via a PAA or pulmonary artery catheter, which is considered the most accurate method of monitoring your SVO2. However, PA catheters are large and can be uncomfortable for patients, so they are typically removed as soon as possible, especially after major cardiac surgeries like valve repairs. Patients who need continuous monitoring of cardiac output or cardiac index may require the PA catheter to stay in longer beyond post op day 1, especially those needing complex monitoring or are on vasoactive medications. So we aim to remove PA catheters as soon as possible to avoid complications, which include pulmonary infarction, persistent wedge. This is when the catheter remains in a wedge position, blocking blood flow, which then leads to ischemia distal to the tip of the catheter. It could also cause emboli, either by air, the catheter, or blood clot. It could cause infection and sepsis. Of course, it's a central line. The catheter could be displaced, the balloon could rupture, and ventricular dysrhythmias or irregular heart rhythms caused by the catheter's presence in the heart. It could be an irritating factor. Do check your hospital's policy regarding the removal of a Swan-Ganz or a PA catheter. At our facility, or at one of my facilities, we position the patient with the head of the bed flat, instruct the patient to hold their breath while we withdraw the catheter and monitor the heart rhythm closely, as removal can often cause arrhythmias. After removing the catheter, we apply pressure until the bleeding stops. We then use Vaseline gauze or a moist sterile dressing, followed by a pressure dressing or Tegaderm, since the insertion site, typically in the internal jugular vein, leaves a significant opening. I once encountered a situation where the patient went into VFib as I began removing the Swan-Ganz catheter. So I paused, reassessed the patient, and once the arrhythmia resolved, I proceeded with the removal. There are also cases where the catheter tip may become embedded in a graft or adhered to a tissue during surgery. If resistance is felt while pulling, it's important to stop immediately. These patients may need to return to surgery to have the catheter safely removed without causing further damage. I want to remind you to focus on the overall condition rather than the individual hemodynamic values, which are rarely significant on their own. Look for patterns in data over time instead of reacting to isolated measurements. Evaluate the whole clinical picture, consider all factors, including that could be influencing the patient's condition, not just numerical values. Your goal is to recognize early warning signs, intervene early to prevent problems from developing or escalating. These principles emphasize the importance of clinical judgment and holistic patient assessment in critical care. So take a minute and do this on your own. Pause the video. But here is how the parameters should match up based on cardiac preload and afterload. Your right preload matches with CVP or central venous pressure because CVP measures the pressure in the right atrium, indicating right-sided filling pressures. Right afterload should match up with pulmonary vascular resistance, PVR, because PVR reflects the resistance the right ventricle must overcome to pump blood into the pulmonary circulation. Left preload should match up with PAWP, as your pulmonary artery wedge pressure reflects left atrial pressure, representing left-sided filling pressures. Left afterload should match up with SVR, systemic vascular resistance, the resistance the left ventricle must overcome to pump blood into the systemic circulation. So we'll talk about the different types of shock that's included in this diagram, but what I just want you to see is that there are different types of shock and their hemodynamic characteristics are different. This diagram is helpful for understanding the different hemodynamic changes in various types of shock, but notice that at the center is microcirculation and it is highlighted, which emphasizes the importance in maintaining tissue perfusion and oxygen delivery, which is compromised in all types of shock. The most critical concept in understanding shock is that regardless of the cause or type, the ultimate result is inadequate tissue perfusion. This means that the body's tissues and organs do not receive enough oxygenated blood to meet their metabolic needs. As a result, cellular metabolism becomes impaired, leading to dysfunction or failure of vital organs. Key takeaway is that the various mechanisms that cause shock, whether they are related to blood loss, as in hypovolemic shock, heart failure, as in cardiogenic shock, infection, as in septic shock, or other causes, are result in the same dangerous all result in the same dangerous outcome, which is decreased oxygen delivery to tissues, leading to impaired cellular function and potential organ failure. Shock is a critical condition where the circulatory system fails, leading to decreased tissue perfusion, meaning organs don't get enough oxygen. This causes impaired cellular metabolism, making it hard for cells to function properly. Shock also triggers an inflammatory response, which can worsen the situation. It can be caused by issues like heart dysfunction, changes in blood volume, or blood vessel abnormalities. Shock impacts all body systems and overwhelms the body's ability to maintain balance or homeostasis, making early recognition and intervention really crucial. Patients often report feeling weak, sick, or cold, though some may feel hot, and may also feel nauseated, dizzy, confused, afraid, thirsty, or short of breath. These subjective symptoms can vary depending on the type and severity of the shock. In terms of vital signs, your blood pressure, cardiac output, and urine output are typically low in shock due to decreased perfusion and poor cardiac output. Heart rate usually is high as the body tries to compensate for the decreased perfusion. Respiratory rate is also increased as the body attempts to improve oxygenation and maintain acid base balance. The priority is to correct or remove the underlying cause. For example, fluid replacement for hypovolemic shock and antibiotics for septic shock, while providing supportive therapy such as oxygen, fluids, or medications to stabilize the patient. When tissues don't receive enough oxygen, cells switch from aerobic to anaerobic metabolism to produce energy. Anaerobic metabolism leads to lactate production, which contributes to metabolic acidosis. The metabolic acidosis then results in cell membrane dysfunction, affecting how cells operate, which could then lead to hypotension due to poor vascular tone and circulation, and neurological changes such as confusion or altered consciousness. It's caused by impaired brain function due to the lack of oxygen and acidosis. Let's discuss the cellular effects of shock, emphasizing how shock impacts the body at the cellular level, contributing to organ dysfunction if left untreated. This diagram illustrates the physiological and pathophysiological response to shock. So, an initial insult leads to decreased tissue perfusion and oxygenation. The body then activates a homeostatic response involving your sympathetic activation, which is why you see an increase in heart rate, blood pressure, and cardiac output. The renin-angiotensin system is also activated to increase fluid retention, which with an aim to raise preload and reduce urine output. Catecholamines and cortisol are activated to provide glucose for metabolism, and there's an increase in your respiratory rate to enhance oxygen delivery. These compensatory mechanisms aim to restore tissue perfusion and oxygenation to maintain homeostasis during shock. The four main types of shock are cardiogenic shock. This is a result of the heart's inability to pump effectively, leading to inadequate cardiac output and poor tissue perfusion. So, for example, after a heart attack. Hypovolemic shock is caused by a significant loss of blood or fluids, reducing the volume available for circulation and decreasing tissue perfusion, for example, from severe bleeding or dehydration. Distributive shock occurs when blood vessels lose their tone, leading to widespread vasodilation and insufficient blood flow to tissues. Examples include septic, anaphylactic, and neurogenic shock. Obstructive shock results from a physical obstruction to blood flow, such as a pulmonary embolism or cardiac tamponade, impeding circulation and causing inadequate tissue perfusion. Each type of shock involves different mechanisms but leads to the common outcome of reduced oxygen delivery to tissues. So, this diagram explains the progression from shock to systemic inflammatory response syndrome, or SIRS, and eventually to multiple organ dysfunction syndrome, or MODS. Shock can arise from various causes, again, like we established: cardiogenic, hypovolemic, distributive, and obstructive, which leads to widespread tissue hypoxia and damage. The body's response to shock often involves SIRS, which is characterized by excessive production of inflammatory mediators like cytokines, resulting in vasodilation, increased capillary permeability, tissue edema, and endothelial injury. If untreated, these inflammatory response can progress to MODS, affecting multiple organs such as the cardiovascular system, lungs, gastrointestinal tract, liver, central nervous system, kidneys, and skin, ultimately leading to organ failure. Shock progresses through various stages. The initial stage is the earliest phase where the body begins to experience decreased perfusion, but symptoms may not yet be noticeable. In the compensatory or early stage, the body activates the fight or flight response to compensate for the lack of oxygen and blood flow to tissues. Progressive or late stage is the fight or flight mechanisms now start to fail, leading to worsening symptoms and further decline in perfusion. Refractory or irreversible stage, now the organs are severely damaged and recovery is unlikely even with interventions. In the initial stage of shock, there is a decrease in cardiac output leading to reduced blood flow. Hypoxia occurs due to decreased oxygen delivery to cells. Clinical signs may be subtle or absent with little or no overt symptoms. The body activates homeostatic mechanisms, for example, increased heart rate or vasoconstriction, to compensate for the lack of perfusion. In the compensatory stage of shock, homeostatic mechanisms respond to the drop in cardiac output. Now, your blood pressure may still appear normal, but heart rate and respiratory rate are elevated. The sympathetic nervous system triggers vasoconstriction, redirecting blood to vital organs. There is now decreased kidney perfusion, which in turn activates the renin angiotensin aldosterone system, or RAS, promoting sodium and water reabsorption and potassium excretion. Patient may exhibit confusion and agitation as a result of reduced oxygen delivery to the brain. If the underlying cause of shock is corrected, recovery is possible. If not, the condition progresses to the progressive stage of shock. In the progressive stage of shock, compensatory mechanisms fail, leading to further deterioration. Patients exhibit mental status changes due to decreased brain perfusion. Cardiac output and blood pressure now start to drop, causing reduced perfusion to non vital organs. And cellular perfusion is shunted, and capillary permeability increases, leading to third spacing or fluid leaking into tissues. Aggressive intervention is necessary to prevent MODS, and that severe metabolic acidosis, specifically lactic acidosis, develops as a result of anaerobic metabolism. In the refractory or irreversible stage of shock, there is decreased perfusion and cardiac output, and this decrease in perfusion and cardiac output accelerate anaerobic metabolism, which then worsens the acidosis. Patients experience profound hypotension and hypoxemia. Hypoperfusion leads to end organ ischemia, progressing to multiple organ dysfunction syndrome or MODS. The single organ failure begins to affect other organs, leading to a cascading failure of multiple systems. Recovery is unlikely at this stage, even with aggressive interventions. This stage marks the point where damage is irreversible and survival chances are minimal. Older adults are at increased risk for developing shock due to chronic illness, as in heart disease or diabetes. There's physiological changes of aging that affect the cardiovascular and immune systems as well. Medications such as beta blockers may mask typical shock symptoms. For example, blunting that tachycardia. An aging immune system is less effective at fighting infections, increasing their vulnerability to sepsis. And confusion and agitation or any changes in mentation due to decreased cardiac output may be misinterpreted as normal aging, unfortunately. Your compensatory mechanisms, again, like your increased heart rate or vasoconstriction, are less effective, making it harder for the body to respond to shock uh, with aging. These factors make early detection and intervention in shock more challenging in older adults. Now, let's discuss the different types of shock. This would be a good time to pause. Cardiogenic shock occurs when the heart fails to pump effectively, leading to inadequate tissue perfusion. Causes include myocardial ischemia or myocardial infarction, or MI. Approximately 5 to 10% of all patients with an acute MI will develop cardiogenic shock. Severe heart failure can impair the heart's ability to maintain adequate output. Myocardial or pericardial infections can weaken the heart muscle or restrict its movement. Cardiac tamponade or fluid buildup in the pericardium compresses the heart, preventing it from filling and pumping effectively. Cardiogenic shock occurs due to impaired ventricular contraction, even when there is adequate or excessive circulating volume. This results in decreased cardiac contractility, leading to decreased stroke volume and cardiac output, which reduces the heart's ability to pump blood effectively. The consequences include pulmonary congestion, so the fluid backs up into the lungs due to impaired heart function. And there's decreased systemic tissue perfusion because tissues receive less oxygenated blood, leading to organ dysfunction. There's decreased coronary artery perfusion. The heart itself gets less blood flow, worsening cardiac function. There is also a reduction in your ejection fraction or EF, further compromising the heart's ability to meet the body's metabolic demands. The clinical manifestations of cardiogenic shock are similar to those seen in an acute myocardial infarction and include chest pain, nausea and vomiting, diaphoresis, there's excessive sweating, decreased urine output, decreased level of consciousness, dyspnea, as in shortness of breath, or crackles upon lung auscultation from all that fluid buildup due to pulmonary congestion, and weak pulses, cool, clammy skin as a result of poor perfusion. The hemodynamic changes in cardiogenic shock is that your fluid volume could be normal or increased due to the compensatory mechanisms working. Your cardiac output would be decreased. Systemic vascular resistance would be increased as the body tries to maintain perfusion through vasoconstriction. CVP is increased due to the backup of blood into the venous system. Pulmonary artery wedge pressure would be increased due to left ventricular failure and pulmonary congestion. Cardiogenic shock treatment involves a combination of medical interventions and nursing care. So, you want to provide oxygen therapy to improve tissue oxygenation, intubation and mechanical ventilation if respiratory failure is present, and give thrombolytics or revascularization procedures to restore blood flow in cases of myocardial infarction, and nitrates to reduce preload and improve coronary blood flow. You can give inotropes to increase cardiac contractility and beta blockers to reduce myocardial oxygen demand. Diuretics could also be used to reduce fluid overload. And sometimes your patient might require intra-aortic balloon pump, IABP, or ventricular assist devices, or VAD, to support circulation in severe cases. Nursing care involves monitoring the heart rate, blood pressure, looking for dyspnea and dysrhythmias, provide oxygen and monitor for its effectiveness. But you also want to very closely monitor your urine output to assess kidney function and fluid status. Hypovolemic shock occurs when there is a significant loss of intravascular volume, leading to decreased cardiac output due to the reduced blood volume. The fluid deficit can be absolute or relative. In absolute, there is direct fluid loss, like when a patient is hemorrhaging, or relative, when the fluid shifts out of the vascular space, like in third spacing. Common causes include hemorrhage, burns, dehydration, vomiting, diarrhea, diabetes insipidus, and third spacing. Because in third spacing, the fluid is moving into spaces where it can't circulate effectively. This type of shock requires rapid identification and fluid resuscitation to restore circulation and prevent organ damage. In hypovolemic shock, there is an acute loss of circulating volume, which leads to a decrease in venous return to the heart, causing a reduction in stroke volume and cardiac output. This results in a decrease in tissue perfusion, impairing cellular oxygen supply, and leading to impaired cellular metabolism. To compensate, the body activates several mechanisms. The sympathetic nervous system increases heart rate and induces systemic vasoconstriction. Blood flow is shunted to vital organs, specifically brain and heart, to maintain perfusion. The hemodynamic changes in hypovolemic shock include a decrease in fluid status due to fluid loss, decreased in cardiac output due to reduced circulating volume. There's a decrease in blood pressure due to reduced perfusion, and CVP is decreased because of the reduced venous return. PAWP is also decreased because of the low preload, and SVR is increased because the compensatory vasoconstriction to maintain perfusion. Treatment for hypovolemic shock includes ensuring a stable airway to maintain oxygenation, crystalloid fluid replacement like your lactated ringers or normal saline to restore volume, administering blood products for hemorrhagic causes, using albumin to maintain oncotic pressure and fluid balance, Nursing care involves managing airway, breathing, and circulation, monitoring heart rate, blood pressure, and respiratory status, assessing level of consciousness and signs of tissue perfusion, and monitoring for signs of fluid overload during aggressive fluid resuscitation. Okay, now let's talk about circulatory or distributive shock. Circulatory shock involves a precipitating event, could be an infection, anaphylaxis, or spinal cord injury, and that triggers the shock state. This leads to widespread vasodilation, which reduces vascular resistance. The inflammatory response is activated, causing further complications. There is a maldistribution of intravascular volume as fluid moves out of the blood vessels and into tissues. This results in decreased venous return to the heart, which then reduces your preload. Consequently, cardiac output decreases. The final outcome is decreased tissue perfusion, leading to impaired oxygen delivery to organs. Neurogenic shock occurs due to the disruption of the sympathetic nervous system, often from a spinal cord injury, particularly at or above the level of T5. Certain diseases affecting the spinal cord above T5 could also cause neurogenic shock. Spinal anesthesia, which can block sympathetic outflow. Vasomotor center depression caused by head injury or drug overdose can cause neurogenic shock as well. The signs and symptoms are hypotension due to widespread vasodilation, bradycardia or low heart rate as a hallmark sign, and temperature dysregulation, hypothermia or hyperthermia. Bladder and bowel dysfunction, there's decreased skin perfusion leading to cool or mottled skin. Flaccid paralysis below the level of the injury. So, in summary, neurogenic shock requires disruption at or above T5 because this is where the critical sympathetic pathways begin. And an injury here cuts off the brain's ability to regulate sympathetic responses in the rest of the body, leading to characteristic hypotension and bradycardia. The treatment for neurogenic shock involves promoting spinal stability to prevent further injury, treating hypotension with fluids and vasopressors to maintain adequate blood pressure. You want to treat the bradycardia, often with medications like atropine or a pacemaker if necessary. Nursing care includes maintaining the patient's airway and providing oxygen as needed. We want to monitor the heart rate, blood pressure, and temperature closely to detect any changes or complications. Anaphylactic shock is caused by a severe allergic reaction to a sensitizing substance like food, drugs, or insect stings. The signs and symptoms include chest pain, shortness of breath, and wheezing due to airway constriction, laryngeal edema causing airway obstruction, itching or pruritus, flushing and swelling of the tongue and lips, anxiety, confusion, and a feeling of impending doom. Abdominal pain, nausea, and sometimes a metallic taste in the mouth is also a sign and symptom. Fluid shifts, so again, third spacing due to increased capillary permeability. Early recognition and intervention are crucial in anaphylactic shock to prevent life threatening airway compromise and circulatory collapse. Anaphylactic shock treatment include administering IM or racemic epinephrine to reverse the allergic reaction. Also giving diphenhydramine to block histamine effects. administering nebulized bronchodilators to relieve bronchospasm, an, endo- an endotracheal tube or cricothyroidotomy may be necessary for airway management, colloids for fluid replacement if needed, and IV corticosteroids to reduce inflammation. Nursing care focus on prevention by identifying and avoiding the allergen. But if they're having an active anaphylactic reaction, you want to maintain the airway and provide oxygen, monitor the heart rate and blood pressure closely, pre medicate high risk patients before exposure to known allergens. Sepsis and septic shock is a life threatening condition caused by a dysregulated response to infection, leading to organ dysfunction and, in severe cases, septic shock. The goal is to stop sepsis and save lives by early identification, quick intervention, and preventing the progression to septic shock. Sepsis is defined as a life threatening organ dysfunction caused by a dysregulated host response to infection. According to Sepsis 3, the third international consensus definitions for sepsis and septic shock, this means that sepsis is a severe condition where the body's immune response to infection goes out of control, leading to widespread inflammation and organ dysfunction. Septic shock occurs when this process leads to profound hypotension, even with fluid resuscitation, requiring vasopressors to maintain blood pressure. Early identification, timely antibiotic administration, and aggressive fluid management are key in improving survival and preventing organ failure in septic patients. In sepsis or also in septic shock, the inflammatory response is triggered by a clinical insult, such as an infection, leading to SIRS or systemic inflammatory response syndrome. This response includes cellular death, catecholamine release, and trapping of neutrophils, which worsens inflammation. The inflammatory response also stimulates the clotting cascade, leading to formation of microemboli in small blood vessels, further impairing perfusion. The depletion of the clotting factors, which increases the risk of bleeding and can lead to disseminated intravascular coagulation or DIC. Early detection through regular screening can help prevent progression to severe sepsis and septic shock. Screening is done every shift and PRN as needed. Use the severe sepsis screening tool to identify patients at risk. Look for the presence of or suspicion of infection. You want to check for the SIRS criteria, the signs and symptoms of infection, such as temperature greater than 38 degrees Celsius or 30, less than 36 degrees Celsius, heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, or a PaCO2 less than 32 millimeters of mercury. Of course, you obtain that through a ABG, and white blood cell count greater than 12,000 or less than 4,000 or greater than 10% immature band forms. Just remember that when your patient is on steroids, sometimes their white blood cell count is also elevated. Sepsis progression starts with an infection and could turn into SIRS, which is an aggressive, widespread inflammatory response to an infection or perceived invader. Sepsis equals SIRS in the presence of a documented infection. It is complicated by dysfunction of one or more organs, and then septic shock is characterized by persistent hypotension despite fluid resuscitation, requiring vasopressor therapy to maintain blood pressure. MODS, or multiple organ dysfunction syndrome, is the failure of two or more organ systems, often a critical and life threatening stage. This pathophysiology explains why septic shock requires aggressive treatment to prevent organ damage and improve tissue perfusion. There is an invading microorganism that trigger the release of pro-inflammatory cytokines like TNF and IL-1, causing widespread endothelial damage. This then leads to increased capillary permeability, allowing fluids to leak into tissues, contributing to peripheral vasodilation and maldistribution of blood volume. The microemboli form due to damage, which then further impairs circulation. Sometimes selective vasoconstriction can occur in non vital organs where the central nervous system and endocrine system are activated to compensate. The body enters a hypermetabolic state, increasing cellular oxygen demand while oxygen supply decreases. This results in decreased tissue perfusion and ultimately impaired cellular metabolism, causing organ dysfunction and failure. The therapeutic goals in septic shock include maintaining adequate intravascular volume. You want to ensure that fluid resuscitation is happening to optimize blood volume and perfusion. In order to improve cardiac pumping, you want to use inotropes if necessary to enhance cardiac output and improve vascular tone by administering vasopressors to maintain adequate blood pressure and tissue perfusion. Treating the underlying cause typically involves administering antibiotics and controlling the source of infection. You want to try to avoid complications by monitoring for signs of decreased perfusion in major organs like the heart, lungs, brain, kidneys, liver, intestine, skin. You want to take preventative measures to avoid complications like organ failure and secondary infections. You also want to prevent complications of immobility. You want to use interventions to prevent pressure ulcers, DVT, and muscle atrophy. It's also very important to support the patient and family by providing emotional and psychological support throughout the critical illness. Diagnostic testing includes arterial blood gases to assess oxygenation, ventilation, and acid base balance. You want to get a chem panel with magnesium, calcium to monitor electrolytes and kidney function, a lactate to check for elevated levels because this could indicate tissue hypoxia and the severity of the shock. You want to send some coagulation tests like your PT-INR and PTT to assess for coagulation abnormalities and the patient's risk for DIC. Liver function tests also to evaluate your liver involvement or failure. You want to check for cardiac enzymes and BNP to assess for myocardial injury or heart failure. A complete blood count with differential to assess for infection, anemia, or thrombocytopenia. A C-reactive protein, which is a marker of inflammation. Plasma procalcitonin helps identify bacterial infection and sepsis severity. Sometimes it's used in place of lactate, but lactic acid is more common, or lactate. D-dimer, fibrinogen, fibrin degradation products, or FDP, to assess for clot formation, especially in cases of DIC. You also want to get some imaging studies to locate the source of the infection. It could be a chest x-ray, CT scan. SVO2 or SCVO2 monitoring in sepsis is also very important. Too low, if it's less than 60%, indicates that cells are stressed and taking up extra oxygen, which suggests an increased oxygen demand. Possible causes include low hemoglobin, poor oxygenation, reduced cardiac output, or inadequate circulating volume. If it's too high or greater than 75%, that suggests cells are unable to take up oxygen, which can be a sign of impaired cellular metabolism. In late sepsis, this is a poor prognostic sign as it indicates severe dysfunction in oxygen utilization by the tissues. Management of septic shock include initiating treatment early to improve outcomes, aggressive fluid resuscitation to restore intravascular volume. You want to aim for a CVP of 8 to 12. In septic shock, aggressive fluid resuscitation is often required to counteract the vasodilation and increase vascular permeability that causes fluid to shift into the interstitial space. So a higher CVP indicates that there is sufficient fluid in the circulatory system to maintain adequate venous return and cardiac output, ensuring that organs continue to receive enough oxygenated blood. By targeting a higher CVP, often around 8 to 12, clinicians aim to optimize the volume status to maintain adequate perfusion pressure and prevent further organ dysfunction. You want to maintain a MAP of at least 65, ensure urine output of at least 0.5 ml per kg per hour. You want to target your SCVO2 of at least 60% to ensure adequate tissue perfusion. Vasopressors are used if hypotension persists after fluid resuscitation to maintain blood pressure. Corticosteroids may be used in cases of refractory shock, and you want to obtain cultures before starting broad spectrum antibiotics to treat the underlying infection. The most important goal of nursing care for a patient who is in shock is, so pause and try to answer this on your own and come up with a rationale. But the answer is C. You want to manage inadequate tissue perfusion. The primary issue in shock, regardless of the type, is that the organs and tissues are not receiving adequate oxygen and nutrients due to poor perfusion. Therefore, intervention should focus on restoring tissue perfusion and preventing organ failure. The Surviving Sepsis Campaign guidelines emphasize a series of critical actions to be taken within a set time frame to improve patient outcomes in septic shock. You want to measure lactate level. Lactate indicates poor tissue perfusion. Elevated levels suggest the need for aggressive intervention. You want to obtain blood cultures before starting antibiotics. This ensures accurate identification of the pathogen causing the infection. You want to administer broad spectrum antibiotics within 1 hour because rapid antibiotic therapy is essential to control the infection and improve the survival rate. Fluid resuscitation is administered at least 30 mLs per kg of a balanced crystalloid of normal saline for hypotension. The goal is to achieve a MAP greater than or equal to 65 millimeters of mercury, which helps restore adequate perfusion to vital organs. Vasopressors, if the fluids do not raise the MAP to greater than or equal to 65, vasopressors like norepinephrine are needed to support blood pressure. You want to identify or exclude the source of infection quickly and eliminate any obvious infectious sources, like if there's an abscess or if the patient is suffering from pneumonia. You want to remove intravascular devices because those potentially infected lines or catheters may be contributing to the sepsis. You want to reassess lactate levels if the initial lactate level was greater than 2, or depends on how your lab processes your lactate values, but it will typically tell you what the range is for normal. Monitor for improvements or signs of worsening perfusion. So you want to keep monitoring your lactate levels. You want to use a dynamic indicators of perfusion rather than static ones. For example, passive leg raise, and if you're checking for capillary refill, or a 15% increase in systolic pressure can indicate improved cardiac output or stroke volume. You want to look at quantitative resuscitation targets, which include your CVP, again, greater than or equal to 8 or between 8 to 12, your SCVO2 being greater than or equal to 70%, and that your lactate levels are trending down and towards normal. You want to control blood sugar levels. Target blood glucose of less than or equal to 180 milligrams per deciliter to reduce complications associated with hyperglycemia in critically ill patients. You want to control hyperglycemia because it can worsen patient outcomes and contribute to complications. And here's why, because uh, high blood sugars can impair the function of white blood cells, reducing the body's ability to fight infections effectively. It could also put your patients at risk for infections because it promotes an environment where bacteria can thrive, increasing the risk for secondary infections. Elevated glucose levels can also damage the lining of the blood vessels, worsening the already compromised microcirculation seen in sepsis. And then high blood sugars contribute to pro-inflammatory state, exacerbating the inflammatory response seen in sepsis and other reasons. Fluid resuscitation in sepsis is critical for restoring tissue perfusion, especially due to significant fluid loss and vasodilation. Massive amounts of fluids are required to replace lost volume and to fill dilated vessels caused by inflammatory response in sepsis. Typically, 500 to 1000 ml of crystalloid, lactated ringers, or normal saline is given every 30 minutes. Alternatively, 300 to 5 ml of a colloid, for example, albumin, can be administered every 30 minutes through the use of though the use of colloids in sepsis is controversial. In certain patient populations, such as those with heart failure or kidney failure, smaller or no fluid challenges may be necessary to avoid fluid overload, as these patients cannot tolerate large volumes of fluid. Again, pause the video, try to answer this by yourself, and come up with a rationale. The best indication that fluid replacement for a patient in hypovolemic shock is adequate is urine output of at least 0.5 ml per kg per hour or at least 30 mLs per hour. Urine output is one of the most reliable indicators of adequate organ perfusion and kidney function. This shows that the kidneys are receiving enough blood flow to filter waste and produce urine, indicating that overall fluid resuscitation is effective and the body is being adequately perfused. Blood pressure and CVP are also important, but urine output is the clearest sign of adequate tissue perfusion in this context. In shock management, Medications play a critical role in stabilizing the patient's hemodynamic status. Here's an explanation of the categories on this slide. Catecholamines and vasopressors are medications such as norepinephrine or epinephrine, which increase blood pressure by causing vasoconstriction, which then raises your systemic vascular resistance and improves blood flow to vital organs. They are essential in managing septic shock or hypovolemic shock when blood pressure remains low despite fluid resuscitation. Inotropes are medications like dobutamine and milrinone. They improve the contractility of the heart, which then increases your cardiac output. This is especially important in cardiogenic shock, where the heart's pumping ability is compromised. Inotropes help improve tissue perfusion by enhancing the heart's effectiveness in circulating blood. Vasodilators are medications like nitroglycerin or nitroprusside, which help reduce the afterload. Again, that's the resistance the heart must overcome to pump blood. By dilating blood vessels, this improves cardiac output and reduces the workload on the heart. Vasodilators are often used in cardiogenic shock to relieve the strain of the heart. Corticosteroids, which are drugs like hydrocortisone, are used in some cases of shock, particularly septic shock, to reduce inflammation and help improve responsiveness to vasopressors. They are also helpful in cases of adrenal insufficiency, which can occur in prolonged shock states. Together, these medications help optimize cardiac output, vascular tone, and perfusion, addressing the different causes of shock and preventing further organ damage. So again, vasopressors are potent medications used in shock management to cause vasoconstriction or narrowing of blood vessels. These medications tighten the blood vessels, which helps to increase blood pressure by improving resistance in the vascular system. By causing vasoconstriction, vasopressors ensure that blood is directed toward critical organs like your heart, your brain, and your kidneys, ensuring they receive the necessary oxygen and nutrients to function during shock. The goal for administering vasopressors is to increase your blood pressure, achieve a MAP greater than 65, improve your cardiac output, and systemic vascular resistance, which are essential for maintaining an effective circulation during shock. So here are a list of common catecholamines and vasopressors used in shock management. Each of these medications act to increase blood pressure and support your circulation by causing vasoconstriction. So again, dopamine at low doses, it can increase renal perfusion and heart rate. At higher doses, though, it acts as a vasopressor, increasing blood pressure by causing vasoconstriction and improving cardiac output. Norepinephrine or Levophed is a powerful vasoconstrictor, often is the first line of treatment for septic shock. It increases MAP by raising both systolic and diastolic blood pressure without significantly increasing heart rate. Epinephrine, again, a potent catecholamine that stimulates both alpha and beta receptors, leading to increased heart rate, cardiac output, and vasoconstriction. Often used in anaphylactic shock and severe septic shock. Vasopressin is a synthetic version of your antidiuretic hormone. It causes vasoconstriction by increasing water retention and raising blood pressure. Commonly used in septic shock as an adjunct when norepinephrine alone is insufficient to raise blood pressure. Now, these guidelines help ensure safe and effective administration of vasopressors. I have seen it, you guys, where a patient got amputated after uh, a mismanaged or dose of vasopressors. You want to reduce the complications while stabilizing the patient's condition. So you want to assure adequate hydration. Before administering vasopressors, it's essential to ensure the patient has adequate fluid volume. Vasopressors cause vasoconstriction and can further reduce perfusion to tissues if the patient is not well hydrated. Again, vasopressors cause vasoconstriction and can further reduce perfusion to tissues if the patient is not well hydrated. The effect on kidneys and other organs is that vasopressors can reduce blood flow to those non-essential organs due to vasoconstriction. It's essential to monitor for signs of reduced kidney function or other organ damage, such as decreased urine output. You want a continuous monitoring for adequate perfusion. Ensure that the patient's organs are receiving sufficient blood flow. This is typically monitored through blood pressure, urine output, and oxygen saturation to assess tissue perfusion. When I look at your map, ensure it is greater than 65. Continuous monitoring for extravasation. If vasopressors leak into the surrounding tissue, extravasation can cause severe tissue damage. You want to continuously monitor your IV site. It's crucial to prevent this complication. You also, as much as possible, want to give vasopressors on a central line. You really shouldn't give it in a peripheral line because of the risk for extravasation. You want to aspirate the line before flushing when the medication is discontinued because when you aspirate the line to ensure no residual medication remains, as a sudden bolus can cause dangerous spikes in blood pressure. You This monitoring applies to vasodilators and inotropes too. So because they can be very potent medications if bolus. Vasopressors can cause rapid changes in blood pressure, so continuous monitoring is necessary to ensure the patient's blood pressure is within the desired range and doesn't rise too high, which can cause complications in its own. Typically, you need an arterial line to check your blood pressure or check your blood pressure every 15 minutes, especially if you are titrating your vasopressors. Don't mix with other medications due to the potency and specific effects of vasopressors. They should not be mixed with other medications to avoid adverse reactions or alter drug effectiveness. Inotropes are used to increase the contractility of the heart, which enhances the heart's ability to pump. So inotropes can increase cardiac output by improving the heart's pumping ability and thereby increasing the amount of oxygenated blood reaching tissues, which is critical in shock states. It also decreases your systemic vascular resistance and PAWP. It has a variable effect on heart rate. Some inotropes may increase heart rate, while others might not have as significant of an effect on heart rate. It can also drop your blood pressure. Inotropes can cause a drop in blood pressure, which is why their use needs to be carefully monitored, especially in patients with low blood pressure already. Inotropes are commonly used in cardiogenic shock where the heart's ability to pump is impaired. They help the failing heart improve its function. Examples of inotropes are dobutamine, amiodarone, and also milrinone, something you will see more commonly. So to summarize, inotropes are critical in treating cardiogenic shock or any type of shock really, where the heart's contractility is impaired. However, their effects on blood pressure and heart rate need to be closely monitored. We use vasodilators in the management of cardiogenic shock, particularly in reducing preload and or afterload. Here's here's the breakdown. Vasodilators dilate blood vessels, either veins, arteries, or both, to decrease the workload on the heart and improve circulation. The example is nitroglycerin, which is my favorite. It reduces preload through venodilation. Nitroglycerin causes venous dilation, which reduces the amount of blood returning to the heart or your preload. This is especially helpful when the heart is failing to pump effectively as it reduces the strain on the heart. It also dilates coronary arteries, so nitroglycerin has is able to dilate the arteries supplying the heart muscle itself, which then improves oxygen delivery to the heart. The CVP, which reflects the amount of blood returning to the heart, decreases as a result of venodilation. Blood pressure typically drops with vasodilators because of the reduction in vascular resistance, so monitoring for hypotension is essential. Now, nitroprusside, unlike nitroglycerin, nitroprusside dilates both veins and arteries, reducing both preload and afterload. This dual effect makes nitroprusside especially useful in severe cases of cardiogenic shock, as it decreases the heart's workload from both directions. The CVP and SVR both decrease, reflecting the reduced load on the heart and the overall drop in blood pressure. So, in summary, vasodilators are used to reduce the workload on the heart by lowering both preload and afterload. That's nitroprusside. This helps to improve cardiac output in patients with cardiogenic shock, but requires close monitoring of blood pressure to prevent excessive hypotension. The Sepsis 3 revisions introduced in 2016 made significant changes to the understanding and management of sepsis. Some of the key areas that were revised were the redefinition of sepsis and septic shock, so and the elimination of SEERS. The SEERS criteria are no longer used to define sepsis. The introduction of QSOFA, which is a quick bedside tool to identify patients at risk for poor outcomes from sepsis. Uh, Defining terminology such as sepsis is defined as life-threatening organ dysfunction from a dysregulated host response to infection, and septic shock is sepsis with persistent hypotension despite fluid resuscitation, requiring vasopressors and a high lactate greater than 2 millimoles per liter. QSOFA used for rapid assessment with criteria including altered mentation, respiratory rate greater than or equal to 22, and systolic blood pressure less than 100. The QSOFA score is used for quick screening at the bedside for patients suspected of infection who are at risk of deterioration. The assessment of fluid status was updated as well. Fluid resuscitation is crucial. Again, the goal maintaining MAP greater than 65 and CVP 8 to 12. Lactate levels are monitored as an indicator of tissue perfusion and oxygenation, so you want to recheck lactate after you've given all those fluids. Dynamic measures like passive leg raises and fluid responsiveness are emphasized for assessing fluid status rather than static indicators like CVP alone. Treatment was also updated. Early goal-directed therapy emphasizes timely fluid resuscitation, vasopressor use, and broad-spectrum antibiotics within the first hour of diagnosis. Vasopressors are administered to maintain MAP greater than 65 if fluids alone are insufficient. Again, broad-spectrum antibiotics are administered early, ideally within 1 hour. Don't forget to check your cultures first. And then lactate normalization is a key target for resuscitation. So in summary, Sepsis 3 shifted the focus from inflammation, the SIRS, to organ dysfunction and early recognition with tools like QSOFA and guidelines emphasizing aggressive treatment to prevent progression of septic shock. Just to reiterate, QSOFA is a quick sequential organ failure assessment, is a simplified tool used to predict the likelihood of poor outcomes in patients with suspected sepsis. So if it focuses on three criteria, again, respiratory rate of 22 or greater, altered mentation indicated by a Glasgow Coma scale, score of less than 15, systolic blood pressure of 100 or lower. If a patient meets 2 out of 3 criteria, they are more likely to experience a poor outcome, including higher ICU mortality. Now, this diagram outlines the clinical approach to suspected sepsis using QSOFA and SOFA scores. Patients with suspected infection, you want to start by assessing the QSOFA criteria: respiratory rate, altered mentation, systolic blood pressure. If QSOFA is greater than or equal to 2, assess further for organ dysfunction using the SOFA score. SOFA variables include now your PaO2, FiO2 ratio, GCS score, mean arterial pressure, and markers of organ dysfunction like elevated creatinine, bilirubin, platelet count, etc. If your SOFA is greater than or equal to 2, the patient is diagnosed with sepsis. If after adequate fluid resuscitation, the patient requires vasopressors to maintain a MAP greater than 65 or has a serum lactate greater than 2, they are considered to have septic shock. This workflow helps guide clinicians in their rapid identification and treatment of sepsis and septic shock. Fluid assessment for septic shock highlights the following key interventions. Your initial fluid resuscitation. Again, you want to administer 30 ml per kg of IV crystalloid fluid, e.g. your normal saline or lactated ringers within the first 3 hours if the patient is hypotensive. You want to give additional fluids, but it should be adjusted based on the patient's response to fluids through ongoing assessments like blood pressure, urine output, and clinical signs. If fluid resuscitation does not adequately raise blood pressure, norepinephrine is recommended as the first-line vasopressor to maintain adequate blood pressure. The goal is to maintain, again, a MAP at least 65 to ensure adequate tissue perfusion. Um, Passive versus dynamic measurement differentiates between two methods used to evaluate a patient's fluid status in the context of shock. There's passive measurement like CVP and SCVO2 are considered passive because they provide just a snapshot of fluid status at a single point in time. The dynamic measurement focuses on continuous or more comprehensive assessment methods. For example, passive leg raise, a maneuver that transiently increases venous returns, simulating fluid administration. So the response can predict fluid responsiveness. Non-invasive hemodynamic measurements like a cheetah NICOM. This system continuously monitors changes in stroke volume index, offering a dynamic view of a patient's hemodynamic response to treatment. So in general, dynamic measures tend to be more reliable for assessing fluid responsiveness than passive measures like CVP alone. For instance, some physicians may ask you as the nurse to perform a NICOM assessment first to determine if the patient is likely to respond to fluids before prescribing a vasopressor. I attach a short video here on the Cheetah NICOM if you're interested. This slide provides key treatment steps for managing shock, particularly septic shock. Broad-spectrum IV antibiotics, administer these within the first hour after recognizing sepsis to quickly combat infection. Draw your cultures before starting the antibiotics to identify the causative organism. You want to track lactate levels to assess the effectiveness of treatment and overall improvement in tissue perfusion. And utilize medications like norepinephrine, epinephrine, or vasopressin to maintain adequate blood pressure and perfusion. Your transfusion protocol, transfuse only if hemoglobin drops below 7 or whatever your order is. And sometimes you want to manage blood glucose, allowing levels up to 180 milligrams per deciliter, which can improve patient outcomes without being overly aggressive in lowering blood sugar level. Here is a patient scenario. Work on this, pause the video, and proceed to the next slide for the continuation. So now you have the following orders. In which order will you implement them? Again, pause the video and work at this on your own. Once you've paused the video and come up with the answers, let's go through them real quickly. First, I would want you to administer high flow oxygen via a non-rebreather mask. The patient is hypoxic with an oxygen saturation of 88%. So oxygenation is critical to stabilize her immediately. You want to give the normal saline bolus over 20 to 30 minutes stat. This patient is in shock, and fluid resuscitation is crucial to restore blood pressure and perfusion. The MAP is very low at 52 and CVP is 1 to 2, indicating volume depletion. You want to obtain your blood, sputum, and urine cultures. It's important to get cultures before antibiotics are administered to identify the causative organisms. Again, this should be done after immediate stabilization steps like oxygen and fluids. You want to start your norepinephrine at 2 milligrams per minute for refractory hypotension after initial fluid bolus. If the hypotension persists after the fluid resuscitation, again, remember vasopressors are required to improve perfusion and blood pressure. And then go ahead and administer your Zosyn um, over 4 hours, and then your vancomycin with the loading dose, because broad spectrum antibiotics should be administered as soon as possible after cultures to target the infection. Following the surviving sepsis guidelines of antibiotic administration within 1 hour. You want to then administer your Tylenol. Your patient's temperature is greater than 101. Lowering the patient's temperature is essential but less urgent than stabilizing her vital signs and treating the underlying sepsis. So again, I just want you to see that this order that I presented to you prioritizes oxygenation, circulation, and infection control, which are the critical goals for managing a septic shock. The complications of shock include acute tubular necrosis. This is kidney injury due to decreased perfusion and ischemia, common in prolonged shock states. Adult respiratory distress syndrome, or ARDS, a severe lung condition where fluid collects in the lungs. Air sacs leading to severe respiratory failure. You got multiple organ dysfunction syndrome, or MODS, a progressive failure of two or more organ systems. A significant and often fatal complication of shock. Infection. In the context of shock, especially sepsis, infection can worsen and lead to translocation of gut bacteria. This occurs when bacteria in the gut cross into the bloodstream, further exacerbating infection. And then disruption of the normal immune response. The body's immune system may become overwhelmed, leading to impaired ability to fight off infections. So gut bacteria translocation occurs in shock because of the reduced blood flow or perfusion to the GI tract. And this causes a decreased flow to the intestinal lining, leading to ischemia or lack of oxygen. Another complication is disseminated intravascular coagulation, or DIC, a condition where small blood clots form throughout the body, consuming clotting factors and leading to both clotting and bleeding problems. DIC is a severe complication of SIRS that occurs when widespread clotting is triggered throughout the vascular system. So here's how it develops. The endothelial activation by the inflammatory response in SIRS causes an abnormal clotting process. This activation then leads to the formation of small clots or microemboli throughout the blood vessels, especially in the microcirculation. These microemboli block blood flow to organs, worsening tissue perfusion. As clotting continues, the body's supply of clotting factors and platelets become depleted. Bleeding So then leads to bleeding. Once clotting factors are exhausted, the patient begins to bleed from multiple sites, such as IV lines, mucous membranes, etc., even though clotting was initially excessive. BIC is difficult to treat and manage because the patient requires both blood products to replenish clotting factors and interventions to control the excessive clotting. This condition worsens organ dysfunction, increasing mortality risk in shock and sepsis patients. Here is a summary